And we're off to a great start. So now I'm gonna turn the program over to Dr. Yang Kim from Stanford, and I'm sure if any of you have been in the cutaneous lymphoma world, you've heard Dr. Kim's name. She is an amazing clinician, researcher, and a wonderful, compassionate physician. She wears a ton of different hats, but she's going to share with us today a little bit about what's going on in the research arena. And just to let you know, she is active in the worldwide clinical research arena and is leading a lot of initiatives around the world. It connects with physicians all over. So it's really fabulous to have her with us today and for her to share a little bit about what's going on in the arena of research. There's a lot, but
yes, there's a lot.
I'll let you roll from here.
All right, thank you. Thank you so much. Thank you. If I could just even figure out getting up here. Do you see that? I almost fell. It's getting older. In any case, let me know if my voice is loud. So if I'm too loud, let me know, because you don't want me in your head too much. It's scary. So anyhow, thank you, because actually I really enjoy, we're all so busy, but we all have to take time, and I encourage my colleagues to do patient education forums, and I love doing it because in our busyness, we all forget why we're doing what we're doing, like why we're like busy 24/7 doing our research. And when we see our patients, and I give hugs to our patients, and I see you here, it brings me to the center. We do this because for you, and it's because you put meaning to everything that we're doing. And I think it's very important that we know that, and I hope you know that sometimes we look like we're too busy or whatever, but it is really, that's why we're doing it. And that's why when I see you all, it brings me also to the focus as to why we do what we do. So hopefully I can give you an update. There's so much. The good thing is that there's so much going on that I have to actually pick certain topics, because there's no way I could stand here 2 hours and then I would still not be done. So if some things are like too much information, please excuse me, we can talk about it later, but I didn't want to focus on one thing and then just miss some of the bigger picture advancements that's available. Next thing is to figure out how to advance the slides. There you go. And I serve on a lot of different industry companies. I consult, and I'm steering committee. And it's actually good to be on it, to have some conflict of interest, because then you want to make sure that the drugs that are being developed in a way that's useful for our patients, not like other lymphomas where you use it differently. So we like to be involved and have close partnership with our industry. One thing I want to tell you is that, and I don't have much time, is that there is now a move to pull the investigators together and working together. And the reason this is new is that we're so busy in our islands discovering new molecular things, therapeutics. Then it's an orphan disease. Orphan disease is less than 5,000 new diagnoses a year across the US as a definition, and cutaneous lymphoma is. And if you work on orphan disease, then it's hard to say big things with the small sample numbers. So obviously the answer is that you should work with other people so that what you discover at your site could be tested broadly in large numbers so that we can have bigger impact. And so everybody can then accept the data, and we use it internationally, universally, and partner with our international colleagues. So everybody feels that's the right thing to do, but in our business, we haven't been able to integrate. So one of the big, I think, update is that in the last few years, the international community have now finally, we are putting the energy into joining hands. So we have an international cutaneous lymphoma consortium. And this is not like a patient registry or anything, but it's a research collaboration. So it's a collaborative investigative network So like the data system collection is the same. We collect the same things. The data dictionary is the same. There's a federated biobank so that patients' tissue and blood, and we can't do anything without your tissue and blood in their own site. And so when somebody finds something, we would use the same method and do it at all the institutions and then collect the data. So without going into it further, I just want you to know that now there's like more than, this is even old data, 75 international sites, including like Australia, Asia, all over, South America, where we're joining hands to collectively generate data. And I think that's big, so we'd like you to look forward to this alliance that's coming about. This is just a slide I just decided to throw in because, which one's a pointer? Okay. Without destroying things here. Is there a pointer? Oh, top part of it? Oh, there you go. I didn't want to flash it into somebody's face. Well, now I need to go back. Okay, so we do have advancement. I don't know which one to show, but in clinical, so for Dr. Abdullah did a great job about the clinical part. So in terms of how we manage patients with lymphoma, we first have to recognize it, suspect it, and diagnose it, because it can look like a lot of other things, as you know. And then one other way we diagnose it is biopsy it, take the blood for Sézary and look at it in the tissue. And then sometimes with that, you can't really tell is it MF or what lymphoma it is. So now we have a lot of molecular tools and we have advancement in the molecular tools, but even in a simple thing as clonality that you hear about, there are now newer techniques. So the old techniques were you can detect one cancer cell out of like 500 total cells, but the newer high throughput sequencing technique that we're using in the last couple of years detects one cancer cell in 150,000 cells. Now that's like 1 in 500 to 1 in 150,000. So the advancement that we've made in the last few years is huge. And not only can we detect, but we can be very specific now. So not only can we think it's the same clone in skin and blood, other compartments, but we sequence it. So we sequence the nucleotide acid sequence so that we can tell that it's an identical sequence with all these new molecular technology. So I just want you to know that now we're at a much better place even diagnostically. And then we have to diagnose it, stage it, and then have some prognosis and to select the treatment. And that's how we do it. And even molecularly, I'll show you in a minute how it's helping us find better therapies. Most of my talk, because we have small amount of time, is going to go on therapeutics because at the end of the day, we all want to know how are we going to be treated so that we could have a normal life. As I was very impressed with the video. I just want to congratulate. It really made me feel very emotional looking at that. But I think it brings to, again, why we do what we do. And we want to make your lives, try to be in a normal life as possible. And that means less side effects too. And it's very important to develop drugs that doesn't make you feel sick. And that's very important. So as Dr. Abdullah nicely pointed out, that we have a lot of different T-cell lymphomas, and most of these therapeutics I'm going to describe is in the T-cell space, so just for you to know. And a lot of times the therapies have to be aligned appropriate to your stage. So if you have very early stage, and like it looks like Brad has very early stage, you wouldn't want to give a treatment that's going to make you sicker and give you side effects and maybe shorten your life. I mean, that would be a horrible physician who did that. But it happens, I tell you. So that's where we educate the physicians. So we want to make sure that when your prognosis is this good in the early stage, you align the treatments appropriately. Because all the treatments so far are not curative, not reliably curative, other than allotransplant, which Tim Kuzel is going to talk about later. So you want to kind of use it wisely. And then the advanced stage patients where you do tend to, unfortunately, succumb to your cancer, and there are subtypes for that have better and worse prognosis, but then you should use something more effective that even with side effects there, it's worth the risk and benefit ratio if you have more advanced disease, but you shouldn't align a toxic drug up here. So, I mean, I think knowing how to knowing this stage, what it means for that patient, the long-term outcome is very important for the physician to pick the right treatment. So this, for example, is a patient with stage 1A, the less than 10% patch plaque. Those patients have a same life expectancy. The smooth curve is the life expectancy of people who don't have MF in the general population. So if your life expectancy over decades of time is identical, then you shouldn't use toxic therapy. And that's an example of that. And that's with some topical therapy, by the way. It's not untreated patients. Now, this is just a busy slide, but just not to read it all. We have a national guideline now, which is another progress we've made. So there is a consensus national guideline called NCCN, where an insurance company like Medicare looks at this to approve drugs. So whatever is on this guideline, and I'm about to go to a guideline meeting Monday and Tuesday coming week, the insurance company has to consider this standard of care and will have to approve it. And if they don't, they are subject to not approving standard of care, and insurance companies should not do that. So your physician should use this guideline to get these drug insurance approved for you. Anyhow, this is a list of systemic therapies that are currently used, and there's a long list, and the physicians need to know how to select them. And I just didn't want to go into details. I'll tell you a little bit about brentuximab that's new. And obviously, we will have to use everything based on stage. Where is it? Here it is. So this is just a bird's eye view of the entire treatment that's available that aligns the early stage with the skin-directed, and we go more into the systemic therapies when the MF or says it's more advanced, or if it's refractory to skin treatments, and then when we go to the more other treatments. Now, these are the standard treatments, and since this is a research update, not how do we treat MF and Sézary with standard therapy, I wanted to not dwell on this, and we'd be happy to talk about this in the breakout. But what advances, therapeutic advances have we made? And this is really exciting because there's so many exciting new therapies in the pipeline. Therapeutic advances not only systemic, although most of the effort is going to systemic therapies, but there are skin-directed therapeutic advances as well. And as you know, we have had for the FDA approval for the second topical agent, which is the topical meclorothamine or Valchlor. The first one was the topical targretin gel, and this was in 2013, and I think that adds to treatment choice. But you have these steroids, retinoids. Imiquimod is a topical immune-enhancing agent that we use for actinic damage, but it also has effectiveness in lymphoma. So we do use that, and it's in the guidelines. We talked about the phototherapy. Now, the new thing is that when you use radiation, you should try to use less. So a lot of the enthusiastic radiation oncologists out there is using too much. So too much, there's no data that giving a lot is better than little. So in that, there's a lot of good data that little is better for your skin in terms of toxicity. So we try to use less. Less is more is a concept with radiation. And usually low dose is what we use. So even whether it's local therapy or total skin electron beam, less is more. So, and when you use less, you can always use it more in different places and different times down the road. So we usually reserve more radiation doses for later. And I'll show you how we combine with immune therapy as well. Some of the new topical things, there is risankizumab, which is a more immune-enhancing agent than imiquimod, which is coming out. The clinical trials are going to open probably early next year, where you put some topical agent on and that will clear. But not only that, there may be some immune-enhancing effect, and distant lesions may go away. I think I have a slide. And then you have this topical HDAC inhibitor. There's another topical agent that there's a pill form of it, and the company has made a topical formulation of the pill. So the vorinostat is a pill HDAC inhibitor, and they made the molecule into a topical agent. So that's another topical agent. And then there's new ways of doing light therapy, the photodynamic therapy, where it doesn't damage your skin. Because the negative of the phototherapy is that it damages your skin. So if you have light, I think this one uses like fluorescent light bulb. It doesn't damage your skin, or we're all in trouble. And then you paint some medicine on, and then you shine the like fluorescent bulb, and it activates the drug, and it attacks bad lymphocytes. So again, you have other forms of light therapy that's different than ultraviolet light that's being developed. This is the Rizikumab paper from my colleague Alan Rook's group, and what they do is they rub the medicine on one site, and then you can have the lesion that you treat go away, but also an untreated site in a distant area that also get better. Now, this is only one center data, so we do need to do it in multiple centers, and that's why we need the clinical trial. And this is the traditional total skin electron beam. You've probably heard about radiation that could be given through your entire skin surface. We've learned, we did the original development at Stanford, and it takes like 11 weeks of treatment, you lose hair, nail, I mean, it's not a good thing. And it then doesn't cure the patient. So if that, after all that, if it cures, then it's worth going through, but if it doesn't, then you want to do something less toxic. So after this, we decided that why not use a lower dose, and we combine it with immune therapies. So, we have published with MD Anderson that we can use now 1/3 of the dose of the total skin that was used to be used traditionally. And even using the 1/3, you can get very good response rate. 90% of patients would have very meaningful clearing of the skin, and a third of them will completely clear. And no systemic agents can really do that. So radiation is quite effective. So you can have efficient debulking of the skin lesions, and that is done only with 12 treatments. So compared to many sessions of light therapy, with just 12 sessions over four each week, over 3 weeks, you can either clear completely in 1/3, and 9 out of 10 patients would have more than 50% improvement. This has much less side effect, and because it's low dose, you can give it repetitively over the course of time in your life, and then you have the option of combining it with immune therapy. So here's a patient with low dose therapy who I didn't want to show the scalp, but he had tumor disease and completely cleared after just the 12 treatments. And now the question is, obviously this doesn't cure either. Higher dose doesn't cure, this doesn't cure. So how can we prolong that nice response? Well, the way to do it is activate your immune system to keep your disease away, and so make your immune system smarter to fight your own cancer in your body. So we now combine this low dose total skin with immunotherapy, such as either interleukin 12 or interferon gamma. We have trials going on with that, as well as interleukin 12, and checkpoint inhibitors, which is like ones that like unleash your immune system that you heard in melanoma, the PD-1 and the PD-L1 inhibitors. So we combine it so that the nice response you got could be durable. So that's the concept. As I said, there's a huge amount of molecular data that has come out. Explosion, as I would say, and it's really nice kind of explosion, because in 2015, just last year, 4 genome sequencing papers came out in mycosis fungoides Sézary syndrome, including our site, and they all came out in the same year. This is huge because it came out in the most highest impact journal. So obviously the work that's done by all the colleagues are high quality. And the reason this is important is that before we are giving drugs like trial and error, like we'll use this one first, if it doesn't work we'll go to that one, So again, as Susan mentioned, we all want to go to more personalized medicine, pick drugs smartly. Well, you need to know what to target in that patient. So this is kind of that start of trying to know more about the patient's genetics, and then trying to see what pathways are abnormal in that patient and trying to address it. So the basic papers have come out now to try to start to get there. We're no way close yet, but it's a start. So this is a paper from our center as an example. that shows various mutations that are present. Interesting thing is in our disease, it's a very complex disease. If it was such an easy to address disease, we would have more reliable therapies now. But mutations that are recurrent are very low in number. It's very different than melanoma. Melanoma, like BRAF, mutations are present in 40–60% of the melanoma patients, and you target that, it affects a lot of patients. In CML, it's the same. In our disease, the mutations are very low in number, and you don't have the same mutations across the board. So it's very hard to generalize with one patient's data, and that's what we're learning, and other centers have also shown. This is a pathway, one of the pathways of T-cell survival for the T-cell lymphoma patients, how the lymphomas can kind of promote their own survival. And you want to try to block this pathway because this is what the lymphoma cells are using to survive. And just to show that this is one from Yale, and then we have two other, one from MD Anderson and Columbia, kind of all saying similar messages. Before I go back to the genomics, not only is the genomics important, but genomics is about the cancer cell, how defective, what's going on in the cancer cell. But the environment that the cancer lives in, the microenvironment, is essential. And microenvironment allows the cancer to grow, or it can kill the cancer. And that's why it's important to target the microenvironment as well as the tumor. And you want to target both. That's an effective therapy. You want to enhance the immune system and make the microenvironment less inhabitable for your tumor cell, while you're killing the tumor cell directly. So this is like the immune dysregulation we see in MF and Sézary. There's definitely some immune defect. And in early stage, we don't see any immune dysregulation. But as the disease gets more advanced, and we do see some more immune dysregulation. And in Sézary syndrome, we do feel that patient's immune system is compromised, but not in the early stage. So don't believe that it's happening in the early stage. And unfortunately, I won't have time to go into it, but just wanted you to know that there's immune dysregulation that we want to reverse and also counter. So a lot of therapeutic targets that exist, and it looks like, I think I started a little late, right? So I still have like 10 minutes, okay. So we have things to target, and you heard the word targeted therapy. So the current era, we want to have targeted therapies. What it means is that you want to target the tumor cells with leaving your normal cells alone to the best of ability. In the old days, like the traditional chemotherapies, it just wipes out everything. So your good cells and the bad cells, so you have infections and whatnot. But now that we know what's tumor and how the tumors survive, like to use to survive, we want to kind of attack that tumor pathway. And then we hope that the normal cells, you less of it, and usually there's some distinction between tumor and normal. So we try to target it in different ways. In CTCL or in cutaneous lymphoma, there are three basic concepts that we target for treatment development. And one is what's on the surface. As Dr. Abdullah said, like the CD30 is sticking out on the surface. So there are molecules that stick out on the cell surface molecules that are very distinct and highly expressed in cancer and not in normal. Well, that's a good thing to target. So we try to, with antibodies, we target and try to locate and kill. And those treatments are, newer ones are brentuximab, which targets that CD30 that Dr. Abdullah talks about. And then we have a phase 3 trial that's at the FDA level for approval for mogamulizumab, which is CCR4. There's another protein. And I'll show you just a few of this drug clinical data. We have other things that I just can't talk about with shortage of time. Anti-Cure3 is another one that's in phase 1 study right now, and looks very exciting. And then we also target the microenvironment, including the immune system is in that microenvironment. And there are many drugs. These are all the drugs that in CTCL that's right now being explored. So this is all downstream, and that's the checkpoint inhibitors that unleash your immune system. There's something called CD47 that if I have time, I'll show you a glimpse, but it's a phagocytes in your environment that are paralyzed by the tumor, and then there's a method to unparalyze that and make up the phagocytes, and they wake up and kill the tumor. So these are all new exciting immune therapy technologies. And then we have, again, a lot of other agents that could affect boosting your immune system. And then within the cell, so there's another way to target things that are in the cell. So we have the cell surface molecule on the tumor cell, but in the tumor, we have a lot of things that are abnormal in tumor. And so there are many molecules, many, which I cannot go into, that are under clinical development in lymphomas in general, but also in CTCL. So I just want you to know that there are a lot of things going on. Right now, we only have 4 systemic therapies that are FDA approved. So in the future, as time goes by, as we sort out which ones are more effective in our patients and safe, we hope to have a more impressive list. And we hope to do better than what we've done. So current treatments like romidepsin, bexarotene, and borinostat, they have about 30% response rate, 30%, 1/3 of the patients respond. We'd love to obviously have 70%, 80% response rate. And the duration of response, usually we tell the patient, even if you respond, it's average is that you stay responding for about 6 months. That's why we have to think about multiple other treatments and pick the treatments in the right sequence, because we know the treatment X is not going to be curative, and we have to use it in the right sequence. And we want this duration to be longer. We want it to be 5 years with one treatment and 10 years rather than 6 months. So that's what we're working on. And so these 2 treatments, like brentuximab vedotin and mogamulizumab, these are the 2 that are in phase 3 trial. We hope that we'll do more of that than ones before. So as I said, the genomics could give you some clues to what to target. So for example, there are mutations in this PI3K, for example, pathway. Then you could target, and it happens to be there's a drug. So it's nice when you find mutations or pathway abnormality and you have a drug already. Those are called actionable targets. If you don't have a drug, then you have to go develop a drug, which may take another 10 years. So it's nice when you have a drug. So this target that most of us found happens to have a drug called duvelisib, and it's used in other cancers and other lymphomas. So now there are trials looking at this in our disease. So the initial trial, they had some early kind of interesting activity, and then now there are clinical trials that combine this drug with other escape routes. Because if you target one, the tumor cells are very smart, they find a way to get around it. So now we have to target multiple pathways. So there are trials that are targeting those multiple pathways. And then we just, two more drugs I'll just show you quickly. And this is the CCR4 target, which is on the cell surface, as I mentioned. And this is nice because not only is it on the cell surface of the cancer cell, but it's also expressed in cells we want to get rid of, which is like there are immune suppressive cells called Tregs here. And it's also on that. So if you can get rid of the bad cells simultaneously as we attack the tumor, that's even like 2 for 1. So this is a 2 for 1-er. So it's good. And there's a drug that's already been made. And in Japan, because it's a Japanese company developed, it's already approved for CTCL. It's already approved there, and we're trying to get it approved in the US. So we did some initial studies just to go forth. And the response rate in Sézary is higher than in MF. And then you have patients like this with erythrodermic Sézary clearing. And then impressively, the Sézary blood cells, just with one treatment, can clear. I mean, if you have it's an effective therapy for clearing the Sézary blood. It doesn't happen with everyone, but when it does, it's very efficient. And it's less immune suppressive. Actually, it's not immune suppressive clinically. Its more concern is that it does immune activate too much. So we have seen some immune related inflammatory conditions that are undesirable, but it's not immune suppressive, which is nice because that's better than immune suppressive agents like Campath, alemtuzumab. So again, this is in the FDA review. And then there's the brentuximab, which has been the talk of the town in lymphoma since it was approved in Hodgkin's and anaplastic large cell lymphoma. But MF and Sézary, as well as CD30, LPD, even in B cells can express CD30. And this target is not expressed in normal cells, so it's good. Kill the bad cells, save the good. So it's a very attractive target, good tumor selectivity. And the way it does is that it binds to the surface CD30 molecule, and the drug gets engulfed by your cancer cells. Inside the cancer cell, the drug is released, which is called MMME. It's a tubulin disrupting agent, and it disrupts the normal tubulin survival mechanism of that cancer cell. It kills that cancer cell. But not only does it kill the cancer cell, this tubulin inhibitor is released in that microenvironment and kills the cells even if it doesn't have the target. So it kills the cells with the target and without the target, and hopefully, since it does it in the local environment, it does leave the good cells alone much more than non-targeted therapies. And so there has been 2 phase 2 trials, including one at Stanford and one at MD Anderson. And because of this, now it's on the NCCN guideline, and now the phase 3 trial is almost finished. And long story short, the response rate is really high. So remember I said 30% is the bar that we've always attained, unfortunately, for the FDA approval. This one is higher response rate at 70%. MD Anderson was 50%, so it's still like around 60% between the 2 centers.